Thank you. So usually, it depends on meet the professor, meet the expert session comes with the different flavors. Where I usually do these sessions, it's actually 4 people sit in the panel and then people present a case, and then we try to act smart and give you our expert opinion on what was done and what was supposed to be done. In the next an hour, probably we are not going to go over too many cases, but we're going to go into the detail of how do you approach a person with diabetes. So it's not presenting a case with the rarest of the syndrome. I usually don't find it. How many of us in this room are practicing endocrinologists? Okay. How many in this room are general physicians? Okay. And how many of us in this room are diabetologists who prefer to practice diabetes? And how many of us are rest of us? How many of us are rest of us? Okay. So this rest of us are doing something which they're not right now willing to disclaim. So the idea behind discussing any case, do we have a power button? Do you have a slide change? So the idea behind any case presentation or discussion is you need to be willing to do what you want to do. And I personally think there are 2 kinds of people, and I'll give you first kind of people. And this is sometime most of us, which say that what the eyes doesn't see, what eye doesn't see, and the mind doesn't know, doesn't exist. Although it sounds that none of us would believe in that, but all our clinical physicians, all the physicians who are actually part of practicing process believe that. And the reason is, someone comes in with a certain disease, you write a prescription and you move forward. Sometimes you're not willing to see the issue which actually is lying deep inside the problem. And the reason behind it is about 98% of the time you would be right. That whatever you write, the patient will get better, you don't have to worry about it. In about 2% of the cases, you actually missed out on something which was there but you were not able to see. So that the second part of the people that you see is the eyes won't see what the mind doesn't think of. And I think we have to be realistic about things and how we approach things. We need to be careful when we're seeing a patient to look and feel what the person is trying to tell. You will not find zebras unless you're looking for zebras, but the unfortunate is that being clinicians, which most of the people in this room are, we find it difficult to find a thin line between looking for zebras all the time and ignoring the common thing, or looking for common things always and missing out on zebras or rare things. And again, honestly speaking, no school, no medical school, no training will teach you unless you're willing to invest some time in how you want to approach these patients. So that's just my general impression or introduction of my few slides which are going to come in. My slide presentation could finish in 5 minutes, and it can finish in about 2 hours, depending on how much interest you have. And I would request you to be part of the presentation, because it's not a oration or anything that I will be giving and there's no question. So please raise your hand. If you don't raise your hand, I'll come to you and ask a question. So again, it's meet the experts for me, or meet the professors for me. So again, be careful. If all of us remember this one single slide, I think we will come out as good physicians. And if any one of you ever is dumb enough to become an endocrinologist like me, you will never forget this lesson. This was the first lesson I learned when I was starting my fellowship in endocrine. And this was the first sentence that my program director told me, and I want to share it with you. And the sentence goes like, if you have one endocrine disorder, then what? You have a higher chances of having another endocrine disorder. So please remember that even a simple endocrine, because if you look at the formation and working of these disorders, you will find out that the endocrine disorders are somehow linked with each other. Thyroid disorder will have dyslipidemia, dyslipidemia will be associated with obesity, obesity will be linked with diabetes, diabetes will be linked with nephropathy, nephropathy. So if you go back to it, you'll find out that everything boils back to one or the other thing. So please try to remember that if you have one endocrine disorder, you're more likely to have another. So again, without going into the details or the ethics of the medicine, let me throw a case to you and you guys let me know what you guys think and how would you want to proceed with it. And I would want to learn how things go. So, a 33-year-old female, not recently, but again, noticed erratic blood pressure, and that was the reason she presented. With a varying high and low sometimes, but pressure reported started rising when she was in her late 20s. So she's now 33, and she has high blood pressure, which is usually sometimes recorded high, and sometimes it's not as high it's supposed to be. She also gives a history of headache, which were initially thought to be related to migraine and now thought to be because of fluctuation in the blood pressure. So how many of us experience people with headache and that's how they find out that they have high blood pressure? You guys see, and please don't be shy, you can be right or you can be wrong. So how many of us see people who come to know that they have high blood pressure that by just looking at their headaches? So I see that too. My question to you would be, is it chicken or the egg? Is it the headache giving you a high blood pressure? Or is it the high blood pressure giving you a headache? And honestly, I don't know how to answer it. One way of finding out for sure that this person has high blood pressure is if someone is not having a blood pressure, headache, and you check his blood pressure and his blood pressure is 150 by 90 or 160 by 90. What does that tell you when you see someone like that? Isn't that probably he had blood pressure for long enough time that his body has gotten used to it and he doesn't feel that he has high blood pressure. Blood pressure of 40 by 90 in someone who's having a migraine attack would confuse me, because I wouldn't know what is the reason before the headache and in diabetes that's important. Because the reason is there's 20 to 30% of the people will present with hyperglycemia and diabetes and high blood pressure, and you need to find out what is causing what. Is it the diabetes leading to high blood pressure, or is it the blood pressure leading to headaches and whatnot? And why is it more important today than ever before? When you're treating diabetes and blood pressure, why is it important now that you need to decide if you need to treat someone's blood pressure or not? How many of us are familiar with SGLT2 inhibitors used for diabetes? Excellent. And how many of us are aware of GLP-1 agonist being used in diabetes? Same. So all these things not only control diabetes, but also reduce your blood pressure. So if I treat someone's blood pressure based on the fact the blood pressure reading was slightly higher because the person was having headache, and we start treating with one of these medication, what would happen? I don't know in Sri Lanka, but in Pakistan, they will call yelling at my office and telling me that I did something wrong because their blood pressure dropped. And you tried to help while they got into trouble. So again, something that you need to think of when you're treating diabetes, high blood pressure in these individuals. So the next part is, so if you look at this girl, you will definitely agree with me. She's not the most fortunate of girls, because if you look at the third part of it, that she had reportedly had a seizure since age of 28, but recently gotten worse. So she developed diabetes at a relatively younger age. How many of you would see, or how many of you are seeing girls or boys, or men or women under the age of 30 with type 2 diabetes? Are you seeing a lot of it, or is it not a lot? So again, she's one of those unfortunate girls who got diabetes when she was even not 30. On top of it, she got headaches. Now you hear that she has seizure disorder at 2, which is also getting worse. So diabetes was diagnosed at 30. Poor glycemic control again. Obviously, she's having seizures. The glucose control is not. She's not accepting the fact that she has diabetes, and uncontrolled due to a wide degree of fluctuation. So it's not only the blood pressure is fluctuating. How many of you would hear in reality that you start asking someone about blood pressure and you tell them that your blood pressure is 150 by 90, how many times would you hear that they will tell you our blood pressure is perfectly fine. We had it checked 3 times at our home, it was perfectly fine. Do you hear it often? No. Okay. So again, I hear it all the time too. When they're in the comfort of their home, watching TV alone, not with the wife, when they're watching TV alone, their blood pressure is better. When they're in-laws, it's the same blood pressure that they have in the doctor's office. This is what we call in-laws blood pressure, or white coat hypertension. So poor glycemic control, wide degree fluctuation, diabetes, and again, other finding in this person was abnormal except for high A1C, and recently checked hemoglobin, urine, and they found intermittent hematuria as well, which sometimes is common, what is seen in diabetes because of early nephropathy as well. Obviously, when I saw this patient for diabetes, when she's been seen by a neurologist for the seizure disorder, she's been seen by a general physician for her blood pressure control. She was also seen by neurologist, the same neurologist who was treating her seizure disorder for her migraine or headache, cluster headache diagnosis. So I saw her for diabetes, and obviously I tried to get more from her family history. Do you find anything in the family history which is very significant as far as her age and the conditions are concerned? Anything? So the maternal grandfather developed diabetes at the age of 68. Is it an early onset type 2 diabetes? This is when probably most of the older men get diabetes. No significant history of early coronary artery disease. So that puts her a little lower risk of developing hypertension. Father had hypertension, diagnosed at the age of 55, but well controlled on 2-drug regimen. So it wasn't a resistant blood pressure that we are talking about. And there is no family history of seizure disorder or migraine. It's important because migraine would tend to run in families, and again, obviously, you'll get history of mother or father having migraine. But in this girl, we didn't have a migraine history. And there was no significant history of any cancer in the family. So what would I tell her when I see her? I will tell her that you're an unfortunate female, have severe metabolic disorders with early onset of complications like nephropathy and whatnot. And on top of it, you have seizure disorder, which Dr. X will be presenting. Again, I would say let's test our clinical skills to find out and dissect each symptom of her and try to find out if we can find a reason why has she all these symptoms. All right? First, she has history diagnosed at the age of 30. Diabetes is diagnosed at the age of 30. Is that normal? Is it abnormal? How many of us are seeing more and more cases of younger people coming with diabetes? Thank you. I'm seeing tons of them. I'm seeing 18 years old, 19 years old, 20 years old. I have as young as, obviously you can talk about MODY and other types of diabetes, but I see a lot of younger kids with a type 2 diabetes coming. So something that you need to care of. So, but if you assess the risks, so if above 40 has a zero risk of having something else, less than 20 has a higher risk, she falls somewhere in the middle, that she's relatively younger, but again something that we can say that it's not some poor glycemic control with wide degree of variation, fluctuation, poor control. I would want to ask our experts, how often would you see in your clinical practice someone who's 30 and is coming up with poor control, and how would you justify, apart from readjusting the medication, do you have any comments on how you would adjust the medication?
It's very unusual to see in that age group. Thinking about the medication, so I don't know the BMI here, so perhaps that will be helpful for me to find out.
I think if I remember right, it was 31.
31 BMI.
She was on the heavier side.
True. So, so the fluctuation in the blood pressure is the odd thing. You know, if it is persistently high blood pressure, it's a different thing. So I'm slightly curious because I want to tell something. Maybe you want to come to that later. So I want to, you know.
Just if you're seeing this fluctuation, just like me, I don't know what's going to happen. So again, so blood sugar fluctuation are more common in 2 or 3 different varieties. If you get old enough that you're not able to take the medication right, and this is not scientific, this is not evidence-based what I'm saying, this is more experience-based. And again, as rightly pointed out, if you're old when someone else is giving you the medication, you're not eating right now, the fluctuations are a little more, and you need to worry about how to control those fluctuations. When you're too young, then you worry about fluctuation because then they're not using the medication according to how often they should be using. How many of us in this room take care of type 1 diabetes? Really? Think again. Type 1 diabetes. Not many. That's surprising. So where do most of the type 1 go? They go to the endocrinologist practicing, or you would refer them? Just out of curiosity. They go to? Endocrinologists. Okay, so that makes sense too. But in most of the countries, the type 1 would be. So there is a condition called diabulimia in type 1, in which you see girls mostly with a high fluctuation of blood glucose, because what they do is they eat and they don't inject themselves as insulin. You know why? Because the insulin, if you don't inject insulin, the blood sugar will go high, they will go into ketosis. Whatever they have taken or eaten would not reflect on their weight. So in turn, they will lose weight because it will cause ketosis. It's just like ketone diet. They will push them into ketosis, they will lose weight and they can eat whatever. But the end result is either they go into DKA, which is diabetic ketoacidosis, or they end up having a too high of a low of a blood sugar ratings. Something that you need to. She is not in that age group that you would think that she's doing that, and she's not insulin dependent either. So again, that's something that would limit that from. So the other question was, she also has seizures since the age of 28, but recently gotten worse. And again, what would be the most common cause of a seizure in a diabetic, or all the causes of seizures in a diabetic? Anything comes to your mind? Hypoglycemia. So again, if they're dropping the blood glucose, they could sometime present with seizures disorders too. So again, something that you can think of. The other thing that you can think, they could have a coexisting other problem as well. So something which led to these seizure disorders, which led to this. So again, but again, we still have to think, why would she develop seizure disorder? Erratic blood pressure. So again, as Wright pointed out, why would anyone who's 33 will develop seizure, erratic blood pressure? It should either be high or be low or be normal. In a worst case scenario, if you have a white coat hypertension or a stress related hypertension, it would be high and then it would be low, a normal. It shouldn't drop low. So in this individual, she was reporting her blood pressure to go up as well as go down, which was still not, which was unusual, and we weren't sure how to treat her blood pressure, because if we treated, she ended up with hypotension and ended up in the emergency room. Had developed headaches which were initially thought to be related to migraine. Obviously, the cause of headache was unknown in her. She didn't have a family history of it. We couldn't pinpoint a certain. We had the eye examination done. We had all the other things done. She also had a couple of other neurological exams done, which didn't show any focal deficit, and we weren't sure why would she have a headache in this time and age. Again, blood test revealed no gross abnormality. Obviously, A1C and recently checked urine showed hematuria. Hematuria is not a common presentation of diabetes as well, but you can see a mild hematuria in early nephropathy. I've seen people with mild, they have microalbuminuria, sometimes they have hematuria, leaking of some blood cells which might result in hematuria. So again, she has all the symptoms of different types of complication of diabetes. So now what? So if you were the doctor seeing this patient, apart from sending him to an endocrinologist who wouldn't know what to do, what would you do extra? So let's try to find out, and let me try to ask the audience. And again, I need to show of hand. So again, obviously you cannot start investigating anything and everything under the sun. So read the case presentation and think of what would you do, where would you start if you had to start looking for the cause of this girl's actual problem, because this is obviously not a regular diabetes case. So I must have come up with this case with some issue which we kind of missed and later on found out. So again, if I'm starting to look for a cause of why the problem started, how many of us would see, if we dig hard enough, we will find a reason because of her erratic blood pressure? So none of us think here that erratic blood pressure could be. So there's one or two hands I see. How many of us would think that if we really investigated the headache, we will get to the point of diagnosis of her cause of all these symptoms? Okay, couple of hands here. How many of us think if we looked at the causes of seizures and investigated her seizure, we will get to the bottom of what the cause of her medical problem is? More hands. Good, fair enough. So again, most of us, at least in this room, are thinking of maybe that's a reason. How many of us would think that we need to stop working on the blood pressure, seizure, headache? We need to work on diabetes and try to find out the cause and how to treat it best, because headaches, seizures, and blood pressure could be the reason that she's having all this. And if we fix the diabetes, everything will be fixed. How many of us think that way? Okay, so more people thinking of seizure disorder to be diagnosed. Obviously, poor glycemic control comes in pretty much management of diabetes. So I will we didn't have much to go about, honestly. So the A1C was high and she had microalbuminuria. How many of us in this room would say that because of the high A1C and microalbuminuria, we need to investigate that first before we treat her for her blood pressure and seizure disorder? Okay, so probably none of you would work out the hematuria or the early A1C, probably some of you, most of you will investigate seizure disorder, some of you with headache, and some of you with erratic blood glucose control and blood pressure control. So, before I go there, did I tell you the history of seizure? No, again, I'm surprised no one asked me what the kind of seizures she was having. So the history of seizure was, and then I'll have a revote. History of seizure was, she had about 10 or 12 seizures in the past, and the most recent 10, 15 of them, which was happening almost fortnightly, were when she would go in the bathroom and someone will find her collapsed on the floor, sometime even seizing and sometime even not seizing, but she would collapse and she was half unconscious at that time. And she never had a seizure outside the bathroom. That was strange when I initially asked her, when did she have it? Because I used to try to ask the exact episode of seizure, and it's usually good to see a observer's account on a seizure to find out what kind of seizure the person is having. And it was difficult for me. The only reason I was surprised was every time it will happen in the bathroom. So now giving you that history, how many of us would think the seizure would be the best thing to look for when we look for the changes in her condition? Okay, same amount. So my whole story didn't impress anyone. I tried, but again, I was not unable to impress them for the seizure disorder. So again, most of you still think that finding a seizure disorder and finding out was the problem. But to your surprise, when no one raised hand, we found out the reason for her problems when we started investigating her hematuria. Now, I've given you the diagnosis. Can anyone tell me how did we diagnose that? Yes. I can come over there. Yes.
Hormone secreting pheochromocytoma within the bladder with micturition when she goes to bathroom.
Are you doing endocrine?
No.
Do you want to do endocrine? Could you please do endocrine? Can I request you to do endocrine? Can the hall request him to do endocrine? So he's 100% right. Actually, we found out that he had hematuria, and she, apart from being treated by the neurologist and endocrinologist and a physician and a dietitian and a nutritionist and a physiotherapist, we somehow forgot to take care of her. And at one time, we decided to do a cystoscopy, and we found out that she had pheochromocytoma in her bladder. So now, let's take a step back and let's get the voting right now. Diabetes at the age of 30. Ooh, doesn't it make sense? So pheochromocytoma can cause insulin resistance, can cause problems with glucose metabolism, and sometimes can present as someone with diabetes. So this probably was the reason, and that was the reason, because I'll tell you, once we dissected the pheochromocytoma, everything kind of cured. So she had this tumor which was lying, which was causing it. The variability of glycemic control was because of variation in the catecholamine surge and decrease. So again, if they were going up, they would cause hypoglycemia, and the same with the blood pressure. If they're going down, they will cause it. So again, something that we need to think of. Actually, I published this article in Endocrine Practice years ago, in which we actually showed a person who had, this case is not the case I presented. This was a case I presented in the previous, during fellowship as well, in which we were able to find that we reversed the diabetes after the treatment of pheochromocytoma. So erratic blood pressure control, again, related to the function status of the pheochromocytoma, something that we need to discuss and maybe think of when we are thinking. Headache is a common presentation of pheochromocytoma. So if at any given time we had artificial intelligence and we plugged out all the things, we could have come up with 3 or 4 things which were related to these symptoms. We could have screened them. Unfortunately, we don't have that. But in this time of Google and all these things, unfortunately, we always curse the Google for giving patient ideas that they shouldn't have. But we never look for ideas that we could get if we Googled. So if there is a difficult case that you think of, you will be surprised how accurately sometimes you can find the diagnosis. The rare syndromes, if you don't know what, you just put in all the symptoms, it gives you the differential. So not only that, but there are other sides as well. Again, so can anyone now tell me why did she had seizures in the bathroom? So the bladder had a pheochromocytoma. It was on the side. What would happen if her bladder is full? It will probably float freely and would not get irritated. When she urinated, when the bladder wall collapsed, it irritated it. It caused a surge of catecholamines, and she had a seizure-like activity. So this unfortunate girl wasn't malingering or lying. It actually happened when she urinated, and then the urine got. So something that we need to be careful when we thought of. Any comments, Sophia, on the presentation? Any points that I missed out on? Maybe how we should have approached and how we shouldn't have approached?
I think anyone in your place would have been in the same steps. It's not easy, it's never straightforward to pick up such kind of difficult cases, but very well done, you did it very rightly.
Thank you. Any comments?
I was just wondering, once her pheo was treated, did her diabetes actually resolve?
It is resolved.
Okay.
It not only the diabetes resolved, her seizures, the headache, everything resolved.
Okay.
Actually, we were lucky it hasn't metastasized. It was localized. We took out the blood, tumor, and she was perfectly fine after that.
Right.
And it's, I think, follow-up year number 9, 8. We hadn't had any problems with
And there
that.
are no secondary endocrine disorders?
No other endocrine disorders. We looked at the pituitary at that because of the polyglandular failure, but again, we couldn't find any other endocrine problem.
That's wonderful.
I think my only thinking is the hematuria itself is very unusual, so I think that needs further investigation. And the second thing is I was thinking maybe you're going to go down the route of MODY, because one type of MODY can come with renal cyst and sometimes can present with hematuria. But I think the blood pressure itself is the extra point you have here to think this is more pheo rather than MODY.
So again, so your point is very well taken. There's a type of MODY, which is a maturity onset diabetes of young, in which you can see some of hematuria in their presentation, and that is a differentiating point in these individuals. Unfortunately, she didn't have that, or fortunately, she didn't have that, because this was something we almost cured after this. And the other thing is that you need to be careful. So again, hematuria for me is always not usual presentation. Whenever I see a hematuria in my diabetes patients, especially in the time when aspirin is not as often used as it used to be before, I look at it more carefully than not. Just 1 or 2 slides on pheochromocytoma. While we are at the topic, it's not a pheochromocytoma talk, so I'm not going to spend too much time. Pheochromocytoma is number one, not that common. It's a rare disorder, and it has all variable presentation, as you can see. So again, it can present with a persistent hypertension, it can present with fluctuating hypertension, it can present with hyperglycemia, it can present with normoglycemia, it can present with episodic, it could present in younger, it can present in older. How many of us have ever heard of a 10% rule? Okay, so if anyone has ever read about pheochromocytoma, if you haven't, please go back and read, because sometime you will be surprised how it is there. And again, something to be, there's a 10% rule in pheochromocytoma, which is actually not a 10% rule. We made it up so it's easier, because it cannot be 10% each time. So some of them are 18%, some of them are 6%, but so we round it up. Because unfortunately, as endocrinologists, we don't have that big of a brain that we should have, so we try to make things easy. So, and as my program director said, that in endocrine, there's either black or white. There's nothing in gray. The problem is, because if it falls into gray, as an endocrinologist, we can convert them into white or black, because it's easier and it's more difficult. So in pheochromocytoma, there's a 10% rule. About 10% of them are malignant, 90% of them are benign. 10% of them are bilateral, so you might find an adrenal gland affected on both sides. 10% of them might be extra-adrenal, so they might be outside adrenal. So if you're looking in this case, this was one of the 10% rule. 10% of them are in children, 90% of them will be in older population, 10% of them will be familial, 10% of them will reoccur. Obviously, if they're malignant, there are higher chances of reoccurring. 10% of them will be associated with a rare disorder, MEN. This is what Dr. Sobia was mentioning, that if you had this tumor in a younger population, you would maybe think of MEN, which is multiple endocrine neoplasia. So you might end up having a insulinoma or a pituitary adenoma along with it. This girl did not have that. 10% of them might present with pheochrisis, and 10% might present with stroke-like symptoms too. So all the variety of that as far as pheo is concerned. If you look at journal outlay, they lie between the sympathetic nerve system change, which is shown in orange. They might be overlapping the distal aorta within the ureter system, within the urinary bladder, as was seen in this girl. And obviously, 90% of them would be adrenal. So your best bet to look for a pheochromocytoma would be at the adrenal area. Okay. So we have some time for another case. So I intentionally discussed more in detail the diabetes and the variable cases of it. Now I would want to change gears and ask you for a more common problem which we see often, but we don't discuss it often enough. And that is a case like this. A 45-year-old male with type 2 diabetes, family history of hypertension, and this is not a trick case like the previous one. This is a simple letting you know, letting myself know what should we be aware of, especially in someone is presenting with certain disorders in diabetes. So 45-year-old male presenting with type 2 diabetes with history of hypertension and obesity, BMI of 36, blood pressure is 140/90, waist circumference is 48, A1C is 8.5 with the cholesterol of 225, triglyceride of 350, LDL is low, and LDL is high. So typically metabolic patients with diabetes, dyslipidemia, blood pressure, obesity, all combined together. So one way of looking at this person is, what is the underlying pathophysiology of it? This is not a diabetes talk, so I'm not going to go over each and everything. We can talk about what is the underlying main pathophysiological, like insulin resistance and impaired insulin secretion. So in type 2, you can technically not develop type 2 diabetes unless you have both of them together. And these two things are insulin resistance and lack of insulin as well. So there's lack of insulin secretion in this. How would you manage with diet and exercise, manage with hyperlipidemia, diet, exercise, weight loss? Would you start statin or not? How many of us will start in statin on this individual? How many of will not start in statin in this individual? Okay. How many of us will start aspirin in this individual? How many of us will not start aspirin? How many of us will refer into an endocrinologist? How many of us would just look at him and stare? So again, these are all the things that you would want to see as far as endocrinologist is concerned, and just to make sure. But the problem doesn't fit here, and this is something that we don't discuss enough. This is, I don't know culturally how much different the different countries are. I know for a fact I asked one of my Indian colleagues and asked the same question, and I asked one of my Afghanistan colleague to give me an answer, and I would love to ask my Sri Lankan colleague, how do they find out about a man having an erectile dysfunction in a private clinic or diabetes treatment clinic? In Pakistan, I know someone has a question regarding this when he's either asking his family to leave, or if he's trying to leave and the wife is just pulling him down. And then I had to kind of remember, hold on, I know what you're asking. Are you having problem in your bedroom? And the answer would usually be yes. So culturally, it's difficult for people to come up and ask. Do you find it easy in your part to discuss or come up with issues like this?
Not that difficult.
It is, okay. So not that difficult, but sometimes it's not as open. Even in the Western world, this is not a question most of us ask, and this is not a question most of the time it is addressed. So again, it's not purely in the third world country that people don't come up with these things, but this is something that we... So the question is, how would you diagnose, how would you evaluate? And ED, you'll be surprised what ED means for different people. So for you as an endocrinologist, you think the definition is exactly what is written here. But for someone who's having some other problem associated with it, they might consider that ED. And unless you ask, investigate, or be specific about things, you won't be able to get your answer right. So again, something that you need to be very careful with. And the worst part is, and I'll go one over time, diabetes, ED, erectile dysfunction, sexual health, they're all sometime related to one or the other. So if you look at it, age is obviously something that you don't have. Duration of diabetes, sedentary lifestyle, obesity, smoking, hypercholesteremia, and metabolic syndrome. The only time I can ask a man to quit smoking, and he quits smoking, is when they have ED. If I tell them that they're going to die from a heart attack tomorrow if they don't smoke, they will leave the room smoking, because they will want to enjoy their life for next one day before they die. But unfortunately or fortunately, if they have ED, and I tell them that this is going to get worse every time you smoke, I've seen people hand over their smoking bags or tobacco packs to their wives that today I'm going to stop. This is the best way, believe me. So test it and try it, ask them to stop smoking. Losing weight can do wonders. And again, honestly, it's easier said than done, but people who lose weight do a wonderful job as far as, especially in diabetes. There are organic causes and as well as psychogenic causes. And there's a whole list of it. Gradual onset versus sudden onset, all situation versus situational. And again, it's written, all of us can read anyways. Reduce or vacant. But can I ask the audience, what is one big, so if a diabetic comes to me with erectile dysfunction, what is one question that I can ask which will help me decipher, or which will help me change my further investigation, if I can ask him one question to find out if he has hypogonadism versus diabetes-related erectile dysfunction. Any idea? One question that could differentiate between both. Anyone? Yes, but again, this is difficult to differentiate between two. What one question can help you differentiate between if someone is having diabetes related versus hypogonadism? Libido. So if you ask a diabetic, how is the libido? The answer is these diabetes people, if they don't have hypogonadism, they have a perfectly normal libido, but unfortunately they cannot perform. In a hypogonad patient, the desire is gone as well as ability to perform is gone as too. So these are two different things. So one of the best tests that you can do to differentiate is just to look at the morning testosterone. So again, that's something that you need to keep in mind how you would want to, again, obviously relationships and all these things count as well. But the worst part as a practicing endocrinologist, and I hate to treat something which I created. And if you look at the medication list which can cause erectile dysfunction, 90% of these are actually prescribed by me. And I don't know what to say as far as, so if my diabetics, I don't prescribe an ACE inhibitor or ARB, Dr. Sobia sees the patient and calls me up and she says that, why haven't you prescribed this person ACE inhibitors when he's hypertension and microalbuminuria? And I have to justify whether. So again, ACE inhibitors, ARB, calcium channel blockers, so there goes all the anti-hypertension down the drain as far as if someone is having ED. And if we cannot stop them, then we end up giving them something to treat the side effect of something that we have already given it to them. Other thing which can cause these is that's antipsychotics, antidepressants, some of the hormones can lead you to that. Obviously, if you're not an endocrinologist, which most of the people are not, simple is to check a morning testosterone level. That will give you enough answers to find out if this is the reason that these people are having. If it's in hypogonadism, your life becomes easy. If the testosterone comes back low, send them to endocrinologists and let them take care of it. If it's normal, then you can look at the medication list, and again, obviously you can look at them beforehand as well. Smoking cessation, reduce alcohol, weight loss, regular exercise, obviously social counseling. General measures also include metabolic control, psychological, pharmacological. This is not the time to discuss the pharmacological treatment, but there's wonderful treatment options available. A poor sexual health lead to a poor diabetes control, poor blood pressure control, because if you're not mentally stress-free, and more unfortunately, some of the time you won't come up and tell these issues to your doctor. So something, if you're seeing someone coming in consistently depressed or having other issues, look and ask about the sexual health as well in these diabetes. Obviously, impact on the patient and partners again, and please do not hesitate to ask. I would stop here and I'll leave the chairpersons to give a comment because the other case will not be able to finish in time.
I think Abbas, audience.
Okay.
I think before we close the session, it would be more appropriate if you can interact with Dr. Abbas Raza.
Chair.
In your personal experience, I'm again coming to the question which you said you will not touch. What is the best drug in your personal experience
Okay.
to start reducing this situation?
Okay, so the all PD5 inhibitors work equally good. Sildenafil, tadalafil, viranafil, they all work perfectly fine. Tadalafil, which is a longer acting. So again, so if you've asked the question, let me answer it while we have the time. There are three medications. Two of them are short acting and one of them is long acting. The tadalafil are these medication available locally here or not really? How many PD medication are available? Sildenafil available here? Tadalafil also available? Okay, so you're familiar with it. So among all these, tadalafil probably works best for the longer duration, because this is called what we call a weekend drug. So you can use it over the weekend and you can use it the whole. They're actually a very interesting. So there's two kinds of treatment that you prescribe for these individuals. There's scheduled as well as need-based. So the two short-acting, the sildenafil and the other medication, is used at the time. So they are per demand. The good thing about tadalafil is it can also be used as a scheduled drug. So tadalafil, if you use 5 milligram of it, the regular dose is 20 milligram. So if you use 5 milligrams every day, you are actually treating their ED on a continuous basis. So when they feel like performing, they will be able to perform. And the good thing is you don't have to plan it. So it's not on-demand kind of a medication. So you keep taking it, the side effects are minimal, and it's been FDA approved to be used on a daily basis. So someone who's sexually active and having significant ED problem can take tadalafil for longer duration and again enjoy a healthy life. There was a very strange study actually which came out recently, not recently, a couple of years ago, in which the men who were using who were not responding to tadalafil or the two short actings which are available, they were not responding to either on demand or schedule basis. What they did, they use tadalafil 5 milligram throughout, and they use sildenafil 50 milligram on demand. And the response was much better than either one of them used as scheduled or on demand. So something that you need to look into and how you would want to treat. I honestly think if these medications are not working in your patient, look definitely for an endocrine disorder. And number two, look definitely in how they are using it. Because these medications work. Especially if you combine scheduled and on-demand combined, they work. So it's difficult. I have few people that actually had nerve damage, and I tried to use them on them, and it couldn't help. So I found out some other reasons for their ED. So if you use them wisely, they work perfectly fine. So if you ask me FDA approval for combining two together, no. So again, it's not combining on a daily basis. So you give sildenafil for 5 milligram daily, on demand you give sildenafil 50 milligram. So you can combine and get a better response. You can even give sildenafil on demand as well. So you give 5 milligram and you give 20 milligram on demand as well. So all these variations you can use. Does it make a logical sense? Actually, no. So if you ask me, if you were doing this study and you asked me, would it make sense? And I would say probably not, because you're already overdosing it and it shouldn't be working. But apparently, in two small studies that they've done, it worked better than the other. So again, something that you can look into it.
It's more like a basal bolus approach.
Exactly.
You have made it absolutely basal bolus. This is the first time I've heard that. So we still have time for a few more questions. We'll encourage you to please question this very captivating speaker while he's here.
While we are waiting, at least in the interest of the audience, because there are a lot of non-diabetologists here, in the first case, how to spot diabetes from other causes? What is your top tips for the audience here? When to think about other causes of diabetes?
Okay, so again, actually thank you, because that's very relevant again. So when would you raise a red flag if you're seeing diabetes on a daily, day-in-day basis? So if you're seeing diabetes on a daily basis, and would you screen everyone with pheochromocytoma, or would you screen everyone for Cushing's disease, or would you discover? So I personally think usually family history is important, which can lead you to investigating further problems, or which can sway you away from. So if 2 or 3 or 5 immediate relatives have type 2 diabetes, then and the person's age is younger and their C-peptide is positive, then you would think of disorders like Moody. If there is if there is a family history of old age diabetes and they develop pre-diabetes, so these are and then they develop diabetes when they're in 40s, I would be less interested in getting their investigation done. Although I'll still have a chance of missing out on rare disorders. But again, in this case, the main points were the fluctuation in the blood pressure and the blood glucose in it. Usually in type 2, if I'm seeing someone, I would see most of the type 2, I'm not talking about type 1. In type 2, you'll see most of them will either have a high blood glucose and their A1C would be high, or they would have a low blood glucose and they will be complaining of hypoglycemia all the time. The fluctuation of, especially with the oral medication, usually doesn't happen. Usually these individuals will either come with an A1C of 8 or more, and that's the time that you would want to switch them to insulin, or they will come up with an A1C of 6.2 for 2 years in consecutive while taking oral medication and not having hypoglycemia. So again, usually the variability in type 2 is not as much until unless we start them on insulin therapy. If there's a lot of variability, I think I'm partly answering your question, but this would be the biggest red flag for me. If their variability is too high and too low, I will have to look at some other reason, because as I mentioned in my previous slide, if you have one endocrine disorder, you're more likely to have another. So I picked up a lot of people with adrenal insufficiency or adrenal tumors because of the low blood glucose they've been experiencing, even when they have high diabetes. So they were hitting lows too often and so that's the time I said maybe I should check a cortisol level. Or if their A1C was consistently higher, even after doing everything, and they're consistently gaining weight. When I'm using medications like SGLT2 and metformin, they're still gaining weight, I will look for Cushing's disease. So adrenal disorders I'll be very careful with. The rare disorders like pheochromocytoma, and I don't know if you had something other in mind as well.
The other things we normally look for is pancreatic cancer, because it can be up to about 2% of the cases. And the last one is, other one we see is ketone-prone diabetes, which is a new diabetes itself, which comes and go really, and sometimes they get rid of the diabetes and get back again another time later. So those are the extra things we do normally go for.
Thank you. Thank you.
And if I can just ask you one last thing. What about the use of testosterone in such kind of men? What is your take on that? Because I mean, sometimes you did pose a question that we have to test the early morning testosterone. Let's suppose if your patient comes back with a lower level of testosterone.
So the problem with testosterone is that, number one, unlike, remember in good old days when actually I was doing medical school and residency, estrogen, progesterone for women was considered as a fountain of youth.
Yeah.
So if you turn 45, you're hitting menopause, you start progesterone and estrogen, and you'll still be Jane Fonda at the age of 80. But that didn't happen. We got to know that it had its own side effect, it caused cancers, it didn't get the benefit then and again. So that's one of the reasons that, again, the Women's Health Initiative WHI study came in and proved that this was not the case. Same is true with the testosterone as well, because when the testosterone, if you look at the headline, the testosterone sales shot out of the roof. The US was not able to keep up with this testosterone because everyone wanted to look like John Travolta at the age of 24 and when they were 80. But they weren't looking, and there were more heart disease, there was more other risk factors, there was more and then we realized, although we still don't have any WHI-like study for men, testosterone is definitely not something, and especially if they're in their fertile age, we kill their fertility or we decrease their fertility by giving testosterone. So testosterone, if I asked the question before that how many endocrinologists were in this room, if I was a general practitioner or someone who's practicing something and seeing, I would never prescribe testosterone to someone until unless he or she has been investigated to the fullest to make sure that everything is done.
Thank
And
you very much.
I've said she for the reason, because there was a study published yesterday in which
Yeah.
they said that testosterone caused improved sexual health in women as well.
Loss of
So
libido. it
loss of
is,
libido,
yeah.
and it has an effect. But again, I would not want to prescribe, if I am a physician, testosterone because of the side effect of it. So if there's one word of caution, don't prescribe testosterone, because it's easiest thing to write a prescription for testosterone, but you can get into trouble for that.
But then obviously the side effects in a man as compared to a female would be different with the use of testosterone.
Exactly. Thank you.
So if there are no further questions, I think we would like to thank Dr. Abbas Raza once again for his brilliant talk, and thank you for your presence.